Um, Thank you, Marie, and thanks everyone for joining in to the webinar. My name's Dr. Shyaman Menon. I'm the Clinical Director of the Emergency Services at Peninsula Health, and we've been asked to present on our winter strategies, particularly focusing on the ED component of our winter strategies at Peninsula Health. So, title of my slide was "What's for Breakfast?" Cultural versus strategy, and I might get you to focus on the cat, because certainly after winter 2017, that was the morale of the majority of our staff within our department. And really, we hear in organizational speak about a very famous quote by Peter Drucker, where culture eats strategy for breakfast, and the challenge is this right or is this true? Patient flow is a whole of hospital approach, and while I'll be speaking about the ED components of patient flow at Peninsula Health, I cannot dismiss the work that we've done at Peninsula Health using a whole of hospital approach, and that has been a journey over a significant period of time for us. We've had a variety of initiatives that are some we've tried and have actually progressed and morphed into different processes, and some still hold true to us. And some of these, such as the countdown to discharge, the ready-to-go process, and the daily operating system, which we call our tiered huddles, are still in place at Peninsula Health as part of our ongoing whole of hospital approach initiatives. Within the emergency department, very similar to the whole of hospital, we've had multiple initiatives that we've started. Some we've actually morphed or tweaked a little bit. Some we've actually abandoned through some of our initiatives. And these are some of the initiatives that we've started, where we've worked on streaming, and we still do an element of streaming within our departments. We did have a doctor up front, and I'll talk a little bit about that concept further down the presentation. We still are doing huddles within our emergency departments, and certainly escalation processes have been sort of well ingrained within our staff to actually manage some of the surges that we're having. Here's some of the results in terms of the 4-hour KPI, and I might come back to these slides, but certainly we all experience we all know what happens in winter. So it happens year after year, and certainly we're trying to actually identify what happened. But certainly if you look at winter 2017, this is a week-to-week performance basis for us. It was certainly one of our more challenging times, not only from a performance point of view, but certainly the care that we were giving to patients, as well as the morale of our staff. And here are a couple of the initiatives that I'll talk about, where we had a change to our model of care and some additional capacity, as Marie's mentioned, to our short stay unit. Patient flow is a whole of hospital approach, and I can't sort of ignore some of these whole of hospital strategies that we've implemented at Peninsula Health, and that is using the countdown to discharge, our green light process, where we actually are transitioning patients to our subacute sites, improving our subacute transfers. We've put some initiatives such as the increasing allied health support over the weekends, and as well as having a weekend discharge coach to facilitate the discharges which occur on the weekend. These approaches have actually shown a significant ability for us within the emergency department to treat our patients in a more timely fashion. And if you can look at the slides, our ED cubicle occupancy, which by an admitted patient, has progressively decreased through the last 3 years, and that has made a significant ability for the team in the emergency department to start treating patients in a more timely fashion. Within the ED, we'll talk about ED models of care, and while I've listed it down as a winter 2018 strategy, it was something that we started prior to winter this year. We'll talk a little bit about the funding, as Marie had mentioned a bit earlier on, and a little bit about capacity. So we're going to talk a little bit about the ED model of care. And following winter 2017, that picture of the cat, our biggest challenge was not only did we have significant access block, significant volumes, but the morale of our staff was actually down. We had quite a large amount of personal leave, and that got compounded by staff picking up more shifts, doing more work, and then taking more personal leave because they were fatigued and tired. And we knew that the quality of care that we were delivering to our patients could have been much better. While preparing for this talk, I went through some of my old slides, and that was our slide that we actually had at a point where we needed to do something different. So we started planning for winter of this year, pretty much at the end of winter last year, because we knew that we had to do something different for the betterment of our staff. We worked on principles before developing the model of care, and our principles were really that we're going to be looking after our patients, we're going to be looking after our staff well-being, we're going to keep the principle of early decision making, and I spoke a little bit earlier on of having the team up the front. We tried that model a little bit, and we talked about whether we could tweak that model a little bit more, because staff certainly felt supported when there was a team up the front, and our patients actually got early analgesia, early plans. So it was actually good for our patients to actually have early decision making. At Peninsula, we've got a process called the Ready to Go, where we identify a patient's actually ready to go to the ward, and the ED component of their care has been completed. Last winter, while we had the process, we probably did not actually follow through on that process because of the amount of access block. This winter, we made a very conscious decision to actually still monitor on it and still keep to process, because one of the challenges that we found was as soon as we dropped following that process off, because staff didn't see the benefit of it on the floor, trying to get staff back onto that process a little bit later on was proving to be a little bit challenging. So certainly one of the key principles from the leadership team was we were actually going to focus and still make staff follow the process while they may or may not see that patient actually move to that ward in a timely fashion. But we wanted to make sure that our Ready to Go process did not fall down. And really key to what we actually did was building an element of trust, and that's building an element of trust within the emergency department, between our teams within the emergency department, building an element of trust between the emergency department and the inpatient units, an element of trust between the emergency department and our GPs, and more importantly, building an element of trust to our community that they can come to our department and receive timely care. So we worked on the ED model of care. We want to work on what the principles were, and we did challenge a couple of old established thinkings within the emergency department, and that is that the work in emergency departments is actually unpredictable. And we also challenged some of the rostering practices that we've actually done in emergency, and Marie touched on a little bit about staffing a bit earlier on, was because the work is actually unpredictable, then we've got to be, our staffing was actually balanced. And if you look at most departments, it's actually one staffing model 7 days a week. We thought that could we actually challenge a couple of those established thinking to see whether they would actually make an improvement for our patients and our timely care. So we moved towards a team-based care. Now, team-based care within emergency departments, it's not a new concept. There have been multiple centres who have been using team-based care in the past, but we really wanted to focus on having a team-based care but not lose the focus of early decision making, and how do we actually build on both. So from mid-March this year, we piloted a process where we team-based and we allocated patients on a metronome to two teams, and they were pretty much allocated at time of arrival. There was no hard and fast rules, so patient one's blue, patient 2's orange, patient 3's blue, patient 4's orange. If it went blue, didn't matter. We just continued that process. And that was both at triage as well as through ambulances. The two specialities that we had was Team 1, which is the blue team in this instance, looked after patients going to the resuscitation room, and Team 2, which is the orange team, looked after patients who were who had a presenting concern with mental health. These were half of our patients, so we kept, as I mentioned earlier on, one of the initiatives we started very early on was streaming. So at triage, you get streamed to whether you're a pediatric or a patient who could potentially be seen in our fast track area. That's one stream, and then everyone else got streamed onto this team-based care. Our former model was pretty much very much a pyramid model where everything moved up to the consultant and the nurse in charge. So you had the consultant and the nurse in charge who were looking at managing, pretty much 43 cubicles and trying to maintain the flow and keep an eye on what's happening. They constantly had a line behind them because they had all these number of staff who were waiting for their input, their advice, their direction in terms of delivering patient care. And that delayed a lot of processes, and that delayed the care that we were providing. So we moved towards a new team-based model where we actually split both medical and nursing into two teams, and we had team leaders in both teams to actually manage the patients in that area. So each team had between 8 and 9 cubicles, and they had their specialty area. The skill mix between the doctors and the nursing staff was split so that if a patient came in, they could be in cubicle 2 with an acute stroke. They would have the same level of care in cubicle 22. So our skill mix was actually balanced across both teams. And we piloted, next slide, sorry. And this is a bit of a complicated slide, but this is how our teams were actually done. The other element that we thought that we would test was going to be, could we actually challenge the myth that where we talked about the workload in ED is unpredictable? Could we actually predict some of the workload within ED, and what could we do if it was predictable? So our data tells us that the workload in ED is actually predictable. You might have a change in the number up and down, but it's reasonably predictable. You know what's going to come through on a Monday. You know what your volumes are going to come through on a Monday. You know when your surges are going to come through. They are very predictable. We thought, could we actually make the workload a little bit more defined? And once again, that's a little bit of a punt that we've taken. So we, in our team, we did our metronomes from 7 till 2. And at 2 o'clock, we swapped our teams. So we had 2 new teams come on, and they would start with new patients being allocated to their team. Any patients who hadn't been seen, who came in prior to the team allocation, they still continued to be looked after by their primary team. So if you came in at 1:50, you're allocated to the blue team, and the blue team would see you ongoing, because the blue team were present till 6 o'clock. The green team will come on, and they would actually see patients who came in from 2 o'clock onwards. So they were always starting with a fresh, a clean slate. And what we found, the things which were demoralizing our staff was, particularly the night shift staff came on to 30, 40 patients waiting to be seen on nights. Many of those patients did not turn up after 10 o'clock at night. Many of those patients were there from 8 o'clock. And because staff were fatigued, they were actually not being picked up and not turned on in a timely manner. So we challenged you actually saying, if we actually predicted some of the workload and defined some of what their workload was going to be, could we actually make a difference to the delivery of care, or the timeliness of the delivery of care that we're providing as a system? What we found was pretty much by about 4:30, most of the patients who had arrived prior till 2 o'clock had been seen. the need to actually hand over the remaining patients dropped. So our clinical risk of handover to another team actually dropped because the number of handovers had actually dropped. And the teams which were coming on to night shift were actually coming on to 10 to 12 patients instead of 30 to 40. So that was the punt. That was the, could we actually do this by tweaking that model? And the organization, once again, that was just decentralizing the decision maker. And we piloted it for 2 weeks. And we went to staff and asked staff to say, at the end of this pilot, do we want to swap and actually flip back to our previous model? And that was the survey result. 97% of our staff did not want to change. The staff actually felt that the model of care that we were doing was actually working for creating the environment for them to deliver care in a more timely way, and they started enjoying the work that they were doing back. We celebrated our success. We built on this a little bit, and we made sure that every small points of success we celebrated, and we celebrated really well. And that was, for a month target where we actually hit 86% on our 4-hour performance. And that was actually celebrated, with staff, and that was a team celebrating up there. And that's a joint team, and that's the other element of this. It was very much a team approach, and that's our medical and nursing leadership team together. That's our medical and nursing leadership in once again in there celebrating that success. We did not forget about our patients. So while we've actually potentially had come across a model which was actually delivering timely care, what was it actually doing? So we know that it's worked really well for our staff. What was it doing for our patients? Were we actually harming our patients by actually getting to this? And we actually looked through a whole stack of parameters. So we monitored our met calls to the ward within 24 hours, but we report on everyone's within 6. There was no increase. In fact, there was a slight decrease in met calls to the ward within 6 hours in this process. Our time to antibiotics for patients with sepsis improved. Our time to analgesia for patients who come in with a fracture has improved. Our time to the cath lab has actually improved as well. So the markers that we're using for patient care had also significantly improved. Our staff were positive. We've seen a decrease in our personal leave this winter compared to last winter. There are multiple factors to it, but I like to think an element of this is staff actually enjoy coming into work because they're coming into a more enjoyable environment. And we've certainly got better engagement in our staff with the model. As I was preparing the slides, yesterday one of my consultants came in, and I'm trying to actually work out why this actually works. And this is a quote from one of my consultants, pretty much word for word, that the morale and the work is better, even on days that we actually did not have as many staff as we did last year. And I think that sort of encapsulates what this model of care has done, particularly for our staff well-being. Moving on to the next bit about the winter demand funding. So certainly the winter demand funding did assist us at Peninsula Health. We were reasonably strategic in allocating that funding within Peninsula. Majority of those fundings were actually not to ED. The majority of the fundings were actually looking at those initiatives that we talked about in terms of allied health on the weekends, weekend discharge coaches. We did have some funding come to the emergency department where we looked at actually increasing the number of senior decision makers. We did have flow coordinators, well, mainly our senior nursing staff, doing a coordination approach, and they looked at areas they can facilitate flow during this period. But we went back to data. So we went back to the data to actually tell us what patients were coming in when, and going back to my previous challenge of do we need to actually roster the same way every day given our work is actually predictable, we took it a step further to actually saying for the days that we then know that we've got increased demand, what is that increased demand of, and what skill mix do we actually need to put in to actually manage that demand, as opposed to just putting another doctor, another nurse practitioner. Certainly our data tells us that Mondays are our most acute day, our highest volume day. So it made sense to us that when we rostered on a Monday, when we had the additional funding, we actually rostered an additional consultant on a Monday. We put two additional consultants on a Monday, because that's when their skill mix was their skill was actually most in need, as opposed to putting an additional consultant on a Thursday afternoon where our acuity wasn't as high and our presentations weren't as high. Yes, there are the peaks and the changes on that, but overall the data was fairly consistent and told us where to put our staff. We knew that weekends were our most challenging days in terms of volume, but we also knew that on Saturday and Sunday the majority of our volume was actually our non-patients who are going home, and particularly through our fast track area and our musculoskeletal type injuries. So we actually added a nurse practitioner to that skill mix to actually to balance some of that skill mix and to add that additional resource. A consultant would have been great, but that's probably not where I needed my consultant. I needed my consultant on a Monday afternoon. And that's where we used a little bit of modeling. We did a little bit of predictability about where we would add staff to this, to actually build a bit of strategy about how we would use that additional funding. And the last bit of the talk was really about capacity. So we did have the opportunity to increase, so we added 12 additional short stay beds on the 15th of August. And we also, with that, what it had done was actually increasing the capacity within the emergency department to treat patients in a more timely manner. Very early data, given that this new beds were only opened in August of this year, also suggests that our admissions to the wards is slightly decreasing since we've actually opened our short stay. This is a short stay versus ward admits over the last 4 years, and what we've seen is a small trend, but a trend showing that the majority of patients are going through short stay and going home rather than being admitted to the inpatient wards. This was winter of last year compared to winter of this year about our patient profile. Key elements here to actually look at was, yes, our presentations were up compared to last year. That was including the increased demand that we had last year. But our left at own risk with patients actually who did not wait, who left, had significantly reduced. So where we've gone from 1,200 patients, we've had 600 over this winter. So we were treating, so although we had increased presentations, we were also treating more patients coming through, which is a good thing for patients in our community. Our short stay admissions had increased, understandably with an increased capacity. But what it did not show, what we've also shown is we've actually reduced what we call the conversion rate. So patients who come in who either deteriorate or who then need to actually become an admission who stay beyond 24 hours, that's actually dropped as well since we've actually put in there. So it sort of gives me confidence that the patients who are going in there were identified as short stay suitable patients. And our admissions have slightly dropped as well for the number of patients we've been treating over this period of time. For our KPIs since that model of care, so this was winter last year, and this is winter this year, and this is a week to week, and we've had a significant jump in our 4-hour performance. And I think a lot of that has been the whole of hospital approach. So the ED model of care The additional short stays were a component of it, but a lot of this is actually contribution is us working together as a whole health service to approach patient flow. This is where, if we break down, so we've had 17% improvement in our performance from winter last year to this year. We've shown patients going home have improved, patients going to short stay have improved, but also patients going to the ward have significantly improved as well. And this is our did not wait data. So we've actually shown that while we're seeing more patients, we've actually are treating more patients as well. And that reduces that risk to our community for the patients coming through to us. We also monitored to actually make sure that, while we were actually performing really well and we were getting patients home in a timely manner, were we doing the wrong thing and they were just going to bounce back and they were going to come back within the next 48 hours to make sure that the care that we were delivering was also appropriate. And we continue to monitor our 48-hour represents, and we have not seen an increase despite an improved performance of getting patients home in a timely manner. We have not seen an increase in patients representing as well. So it comes back to my theory about, is it culture or is it strategy? And I think it's actually both. I think you actually need both. You need a mix, and you need to probably add structure in the middle of that to hold that two together. So, can't build on strategy without a structure, without a culture, with a good culture. You can't build on culture without a good strategy, and you can't build a good strategy without a structure. And I think you need all three components. And for us, all these three components gelled in at the right time for us to make a significant difference to our to our delivery of timely care to our patients. And here are a couple of quotes. So culture outperforms, but culture with strategy is probably where we want to be. And certainly, a quote from Steve Jobs is managing your strategy, your people, and your products, and the bottom line will follow. And the bottom line is the care that we deliver to patients for us. I do have to make some acknowledgements to the board and the executive of Peninsula Health. A particular mention to this chief executive, Ms. Felicity Top, Mr. Brendan Gardner, and Mr. Tim Williams. They gave us the license to actually test a couple of these hypotheses and challenge some of the old thinking. To my ED leadership team, so Dr. Starling, who's my deputy, Trish O'Neill, the ops director, and my two NUMs, Alyssa and Shreyas. To Nick and the improvement team for assisting us with actually putting a little bit of strategy and structure with all the data that we've actually done to show what we've been doing, and the team at Peninsula Health, because an ED is a component of the patient flow. It's not the only component, and this would not be able to be done without them. But mostly, my most importable asset, and everyone who's come to visit us asks, how have you done this? I've done this with this group of people. This is the reason for the success. It is my team. They've done remarkably well. Done? Yep. Yep. Okay, so it's a question from Carol Ann at Bendigo. Hi, Carol. Can you expand on discharge coach role? Is it a doctor, nurse, or an allied health professional? For us, it was a nurse, and the discharge coach works on the wards to coordinate. So one of the things that Marie talked about was the coordination of discharge to making sure. So we've got a countdown to discharge process at Peninsula Health. The discharge coach went in on the weekends and worked with the medical teams to facilitate that ongoing coordination to make sure that patients who were identified for discharge had all the components of discharge streamlined so they could be discharged in a timely manner.
I've got one question,
Yep.
Shyaman. What's one thing that you would do differently next year?
So we've got our winter debrief next week within the department. Given that it started off as a pilot, I think certainly a group that we would engage more would be our clerical staff, and they've actually built into our team to actually build our model a little bit more. I think for next year, it's actually looking at, so we've seen almost a 3.5 to 4% increase in our presentations to actually test the hypothesis, would this model still work based on our current staffing models for next year. Certainly, I don't know if there's going to be the capacity of funding next year. What are we going to do if there isn't that funding to actually help us out for next year? What are our strategies for that, which are going to assist us, and then building on that as we go along. But certainly, I think a key message that certainly that we've learned is actually working with our staff is probably going to be the key ingredient for us. And whatever we do, we build it together.
Thanks,
Sorry?
Shyaman. I just want to ask, you talked a lot about having a whole of hospital approach. How
Yep.
did you engage the rest of the hospital in that approach?
A lot of it was trust. So it was actually building an accountability within the emergency department for the care they're delivering, and then being open to particularly our inpatient colleagues to be able to facilitate a very mutual, respectful discussion about patient care and what's the best for a patient's care. So a lot of it was actually opening that conversation, building that trust, and then working through from a patient, working through it from a systems perspective. So lots and lots of coffees with our head of medicine, our head of surgery, our head of peds, head of ICU, really to actually understand what their concerns were and trying to address that. It's actually trust. It comes back down to trust.